but it's okay. I just put some images together, and I'm sure it's gonna be great.
Okay, that will be good. You can start just make test for screen sharing to check if everything is okay before we start.
Okay, so I just hit share screen, and this is my lecture.
Okay.
Can you see it?
We see it, but it's not. No, yes, it's great. Great. Now it's great. Perfect.
It's
Yes,
good?
now it's good. Very good. Okay.
Okay, should I stop
Yes,
sharing? Or do you want to
you
show
can stop.
anything before?
Okay, you can stop sharing. In 3 minutes, we should start. I'll do welcome talk and then introduce you, and then you can start. Inshallah.
Okay.
I think Dr. Abeda is already here or not yet? Not yet. Try contact him before. I think it's already time. We can start. Hello, Professor Abeda.
I am available. Good for you. Hi, Dr. Binashah. How are you?
How are you? Okay. You are muted, Doctor. We cannot hear you. Dr. Abeda, you are muted. Let's check.
I think you, the host, can unmute people.
Let's check.
Okay. Hi.
Okay, that's good.
Hi, Eduardo. How
How are you?
I'm fine.
How are you, Doctor? Thank you for joining us.
Hi, Eduardo.
Hi, how are you? Nice to see you again, Dr. Binashah. It's
nice to see you.
It's fun to take these congresses, these meetings all around the world. So you see people in the morning, in the late afternoon, in the night.
Yeah.
I think you are one of the latest today. You're already in night, right?
Yeah, already night. Already night. Yeah.
Okay. So welcome everyone to this comprehensive neuroanatomy educational course organized by Yemen Neurosurgical Society in collaboration with the WFNS, Young Neurosurgical Forum, and Water Dandy Student Club, Yemen, and the Pakistani Society of Neurosurgeons, and also Neurosurgical Coach, and the Neurosurgical TV. Today we have two distinguished speakers. First, we have Dr. Eduardo Ribas. He will talk about the anatomy of the meninges, I think. Yes, doctor. And then we have Dr. Abeda Shah. She will talk about the anatomy of the cavernous sinus. Dr. Eduardo, please introduce yourself and you can start.
Okay, I'm gonna share my screen. First of all, I wanna thank for the invitation for this comprehensive neuroanatomy course and to have the first lecture. So today I'm gonna talk about the Meninges and aspects that the neurosurgeons need to look for when he needs to understand about this organization of the Meninges. So we have the peripheral and the central nervous system. The peripheral nervous system consists of the nerves that is going to the muscles, to the organs, really outside this space made of by the skull and the spine. Inside the skull and the spine, we'll have the central nervous system, and then the central nervous system is inside a space made by the meninges. Actually, the meninges folds around lines around all the central nervous system, but it also has folds inside that's gonna divide, especially the encephalon, its parts. So we have these inner folds. This that I'm pointing is the fox. The fox is dividing the brain into its two separated hemispheres, so one on each side. And then we have the tentorium, also called the cerebellar tentorium, because it's over the cerebellum. And because of the tentorium, the intracranial space is divided into a supratentorial and an infratentorial compartments. So this is a key understanding about how the intracranial space is subdivided. It's subdivided by this fold of dura mater called the tentorium. This is an illustration that I got from the internet, and we can see how the fox connects to the tentorium. It's actually one fox. The one fox is dividing the brain into two paired hemispheres, right? The left and right hemispheres. And then the fox opens itself into the tentorium. And of course, we have the midline of the tentorium higher than the lateral aspect of the tentorium. This is a key aspect for the understanding about the infra and the supratentorial approaches, because once you get closer to the midline, the infratentorial approaches are going to be wider. So that's why we want to go close to the midline. And when you go off midline, the more lateral you get, the more inferior you get related to the tentorium. This is a key aspect. And we're going to talk about this opening of the tentorium a little bit later. This opening of the tentorium is called the incidural space. Incisure is the opening of, in anatomy, is a hole, is an incisure. And this is the tentorial incisure. This is where the brain, that it's in the supratentorial space, continues underneath with the brainstem that is already at the infratentorial space. Okay, so it is continuing through the this incisure, the tentorial incisure. When you talk about the meninges, we are actually talking about the triple layer made of three separated meninges. Coming from outside in, we have the dura mater. The dura mater is the more thicker one, and it's really folding, laying all the CNS, and it is the outer layer. We're going to talk about later how the dura mater is really folded by two separate layers of dura mater. The outer one that it's facing the bone, it's called the periosteal dura mater, and the inner one that is folding towards the brain is called the meningeal dura mater. On the convexity, this is not really important for the neurosurgeon. But you need to understand that when you come to the midline, they both are going to detach between themselves, and the space between themselves is going to harbor the venous blood called the sinuses. This is a view of the superior sagittal sinus. So understand the sinuses as a space between the two folds of the dura mater, the two separated layers of dura mater. The outer one that is facing the bone is called the periosteal one, and the one that is facing the brain is called the meningeal one. I'm going to talk about this later when I'm going to talk about the cavernous sinus as well. Underneath the dura mater, we have the arachnoid mater. And what you need to understand is that the arachnoid trabeculi is going to come from the arachnoid towards inside the brain, towards underneath, towards the pia mater. And the subarachnoidal space, the space that I'm pointing here, is this multi-trabeculate space made by the trabecula of the arachnoid. Between the trabecula of the arachnoid, CSF is flowing here. So where is the CSF? The CSF is at the subarachnoidal space. Is between the arachnoidal mater superiorly and the pia mater already attached to the cerebral parenchyma, to the brain parenchyma. So between these two layers, we have the trabecula, the subarachnoidal trabecula, and the CSF. Also, we'll have the vessels, the veins and the arteries. They are over the brain, but not really directly in contact with the brain. We have the brain, then we have the pia mater, and then we have the vessels. And the vessels are really inside the subarachnoidal space. This is important for us to understand how we are going to dissect and get inside the subarachnoidal space. Most of our surgeries address for example, vascular lesions. The vascular lesions are inside the subarachnoidal space. And this is why we need to open these cisterns, these spaces, and we make this by cutting, by microdissecting and cutting and dividing these arachnoidal trabeculi. So keep this image in mind. This is an image made by David Peace. David Peace is a famous illustrator that was working with Dr. Rotten in the 80s, 90s, and 2000. And what he shows here is these inner folds of the dura mater. The dura mater is, of course, lining the inner surface of all the skull. So all the fossas, inferiorly, the skull base, but also the inner surface of the convexity. And then it folds inside, making here the fox, and then later the fox opening into the tentorium, lateral, the right and left tentorium. What he wants to show in this image is how the fox contains the two sagittal sinuses. We have a superior and one inferior sagittal sinuses. And these sinuses are having the venous blood from the brain and draining posteriorly. The superior sagittal sinus draining through to the torcula, and the inferior sagittal sinus draining through the straight sinus. And then the straight sinus will drain into the torcula. This is important to understand about the fox. So the fox contains these two sinuses, one more superiorly and the one more inferiorly. And the one more inferiorly will drain into the straight sinus. And the straight sinus is really on the higher aspect of the tentorium. So the higher aspect of the tentorium will have the straight sinus. This is important for whoever wants to come, for example, from a interoccipital approach. The surgeon might, for example, wants to cut the tentorium to reach, for example, the pineal region. Where he will make this cut? He needs to understand that this cut cannot be made on midline, because midline will harbor the straight sinus. So he will have to come off midline. This is very important for the neurosurgeon, okay? Also, the tentorium usually has some space, some lacunas inside made of venous blood, okay? So when cutting the tentorium, you might get some venous blood, and most likely they are related to these lacunas, and you need to deal with them, cauterizing these lacunas, okay? And then on the posterior aspect of the tentorium, you have the sinus here, the transverse sinus. And the transverse sinus will receive the venous blood coming from the torcula, and will drive this blood into the sigmoid sinus later. So you need to understand this division about the dura that is superiorly to the tentorium from the dura that's inferior to the tentorium. This is a transition between the supra and infratentorial spaces. this transition posteriorly will have the transverse sinus. So if you are making one approach that is supra and infratentorial approach, you need to consider that in the middle of this approach, you will have the transverse sinus. This is very important because usually you will not want to cut the transverse sinus. You will have a lot of blood here, and you will interfere about the venous drainage, the venous drainage of the brain. So okay, so keep in mind the location of the transverse sinus. This image here, I just want to show the two sagittal sinuses, the superior sagittal sinus draining posteriorly into the tentorium, into the torcular, and the inferior sagittal sinus draining into the straight sinus and then the torcular. And of course, you have the transverse sinus here dividing the supratentorial from infratentorial space, but always consider this when making for example, a suboccipital approach. That's an approach designed for the infratentorial space. You do not want to go very, very high, because if you go very high, you will face the transverse sinus, and you most likely don't want to face it. You want to keep it usually underneath the bone. So always remember this transition here. Okay. So now I'm going to talk how the brain is divided. So you see the encephalon here. This is a lateral perspective. And look at here to my cursor here, to my mouse, where I'm pointing. Here is the division between the brain superiorly from the cerebellum inferiorly. Inside here, we'll have the tentorium, the cerebellar tentorium, because it's superior to the cerebellum. This is a picture of the skull base. So I just removed the brain, and we are looking from upside down. And we can see how the dura mater, the meninges, are really lining the fossas. We have one anterior fossa, one middle fossa, and one posterior fossa. And the dura mater is just lining these fossas. If we open the tentorium, of course, we will see what is underneath. What is underneath is the cerebellar hemispheres laterally, and the cerebellar vermis on the midline. Anterior to the tentorium, we'll have this opening of the tentorium, this natural opening of the tentorium that, as I said, is called the tentorial incisure, or the Pacchionis foramen. And inside this foramen, we have the higher aspect of the mesencephalon, the midbrain. So here is the higher aspect of the midbrain. This is just the structures of the infratentorial space. So underneath the tentorium, we'll have the cerebellum, posteriorly and laterally, and on midline, we'll have the brainstem. The brainstem divided into three stages. We have the midbrain, the pons, and the medulla oblongata. Is not really a lecture about this. And then we have the brain divided by the falx into its two cerebral hemispheres. It's interesting to know that the cerebral hemispheres are really detached from one another. They are just connected together by the commissural fibers. So the only fibers that connect both hemispheres are really into the interhemispheric fissure. They are called the commissural fibers. And what I want to show in these pictures, how the neurosurgeon that wants to do, for example, an interhemispheric approach, he will go really close to the falx, between the falx and the medial surface of the brain. And he will work between the bridging veins. The bridging veins are draining the convexity, the venous blood from the convexity, inside the superior sagittal sinus. And it will make this leap over the interhemispheric fissure. This is why it's called the bridging vein, because the bridge is making this leap over this space. And the surgeon, of course, he cannot harm one of these bridging veins, because he will interfere with the venous drainage of a big region of the brain. So the surgeon will not harm these veins, and will have to work between the veins. And this is, of course, already a limitation of the approach, because you cannot open this very, very widely. You have to work between the bridging veins. The bridging veins can open into the superior sagittal sinus as multiple veins, as a multitude of veins, or it can just open as one big vein. When several veins are collect themselves into one big vein, and this one big vein will make this the surgeon will work really close to the fox, between the fox and the medial surface of the brain. And what I want to show in this picture here is that between the inner surface of the brain and the fox will not have a lot of subarachnoidal trabeculi. We'll gain this space very easily down. But once you have just superior to the corpus callosum, then you'll see more multitrabecular space. This is the supracallosal cistern. And this the neurosurgeon will have to do the microsurgical dissection, and then underneath this trabecula, he's going to face the pedicallosal arteries, okay? And then later the corpus callosum. So this is the anterior fossa. Lining the anterior fossa, we'll have the meninge, okay? And then if we want to go, for example, to olfactory groove meningioma, we will have to go very sharp, very close to the that's lining. He will go, the surgeon will go between the frontal base, the frontal cerebral base, and this dura mater here that is lining the anterior fossa. And one of the aspects here that the surgeon needs to consider is that the orbit is a little convex towards the surgeon. So the surgeon will most likely have to go extra duro and drill the superior aspect of the orbit. So he will have this approach more shallow. He will also have to drill a little bit the lesser wing of the sphenoid bone. So the surgeon will go extra duro and drill, for example, the lateral aspect of the lesser wing and also the superior aspect of the orbit. And then he can have this more shallow approach. So now I'm coming from here more intradural, and I can see the optic canal. Why? Because I drilled the lesser wing of the sphenoid bone. And I can see also the olfactory groove here where the olfactory tracts are related. Why can I see? Because I drilled the superior aspect of the orbit. And by drilling this extra duro, you can push this duro more inferiorly, more towards the base. And then you can have this view towards the anterior fossa, but also towards the, for example, optic cistern here to see the beginning of the ICA, where most commonly we'll see aneurysms, okay? So why do you drill these bones? To push the dura mater more basally. So I'm trying to relate this anatomy about our neurosurgical procedures. The incidural space, between so the middle fossa and the posterior fossa, but is made, of course, by the two layers of the dura mater, as I said, the endosteal layer and the meningeal layer. And if we want to see, for example, the lateral wall of the this peeling. This peeling means the detaching. We are just pulling the endosteal layer of the dura mater from the temporal base, from the middle fossa. And then what happens that the endosteal layer will detach itself from the meningeal layer. Okay, sorry, what's overlining here is we are taking out the endosteal layer, leaving the meningeal layer, and then the meningeal layer is facing the inner surface. Okay, sorry, the endosteal layer is facing the inner surface, the cavernous sinus. So the cavernous sinus will not bleed too much because the venous blood inside the cavernous sinus is contained by this layer of dura mater. And of course, you can see by transparency, for example, the Meckel's cave here harboring the Glaserion ganglion, V1, V2, V3, the fourth nerve coming here and the third nerve coming here, and you can open the triangle that you want to open to get inside the cavernous sinus. And this image here, I just removed this inner layer. You cannot do this surgically because otherwise it's gonna bleed too much. But I just want to show what is medial to this lateral wall of the cavernous sinus. So we have the glacerian ganglion here, V1, V2, V3, and superiorly we have the trochlear and the oculomotor nerve. And the surgeon will get inside this nerve. These are the triangles of the cavernous sinus. This is not really a talk about this, but I want this to inform you that this is why we make this peeling. This peeling is this separation of these two layers of the dura mater. Then we have the incidural space. The incidural space is made laterally by the free edge of the tentorium. Okay, so this is the free edge of the tentorium. The free edge of the tentorium will go, I'm just going to go back a little bit here. The free edge of the tentorium is going to go to the temporal apex, and at the temporal apex is going to open in the petroclinoidal dural folds. We have a posterior petroclinoidal dural fold and one anterior petroclinoidal dural fold. And then between the posterior and anterior clinoid processes, we have the interclinoidal dural fold. These three dural folds will make the oculomotor triangle at the roof of the cavernous sinus. So remember, the free edge of the tentorium will get to the petrous apex, and at the petrous apex is going to open into one anterior and one posterior petroclinoidal dural folds. And we have a third interclinoidal dural fold here. Remember this image here, okay? Coming back to the incidural space, and now the posterior, our posterior approaches. This is a very large suboccipital approach. I just removed all the bone that is that were posterior to the cerebellum. And if we remove all this bone, we will face the cerebellar hemispheres laterally and the cerebellar vermis at the midline. Remember this transition between the supra and the infratentorial space. This transition is made by the tentorium, of course, but posterior to the tentorium, we have the transverse sinus, and we do not want to harm the transverse sinus. Also, very laterally to the dura that is overlying the posterior aspect of the cerebellum, we have the sigmoid sinus. So we cannot go very laterally, otherwise we're going to face the sigmoid sinus, and we cannot go very superiorly, otherwise we're going to face the transverse sinus. So the suboccipital approaches are going to be at this region here. If we want to go superior to the cerebellum, remember that the superior surface of the cerebellum is draining superiorly into the sinuses that are inside the tentorial the tentorial meninge. It's called the tentorial sinuses. And Dr. Abuser with Dr. Ture, they have a really nice article about this, how to make a cut here, detaching one of these bridging veins. So do not harm these bridging veins. They are draining the superior aspect of the cerebellum. Of course, in some cases you have to divide some of them because they're going to be really at your approach. But especially if you see a large one, don't harm. Go to this Dr. Tures and Dr. Abuser article. They will make a cut here and detach. It's a very recent article and very nice. And remember that the tentorium is higher at midline. So if you want to go really inside, infratentorial, supracerebral approach to reach the incisura and later on to reach the pineal region, for example, you want to go really close to the midline. Perhaps not really at midline, because at midline, the cerebellum, the tentorium will be higher, but also the tentorial surface of the cerebellum will be higher as well. So you want to go paramedian, but close to midline. Okay, so if you take this midline and go really in, you're going to see the pineal here. This is not a lecture about the veins here, but you see here a confluence getting together, a lot of veins here. These veins are getting together to form the Galen and Pola, and then the ampulla of Galen, the great vein of Galen, is going to drain inside the straight sinus. This is a very risky place to deal with the veins. So you don't want to really to detach and identify all these veins. You just want to push them up or laterally and try to make them safe using cotton, for example, or a cottonoid. And here we have the pineal gland here. If you go a little bit more laterally, as I said, the tentorium will be lower, but also the tentorial surface of the cerebellum will be lower as well. So some people will consider going into this paramedian approach to the pineal region. This is, of course, a very nice approach. And this is image about from the Rotten collection. This is actually is not my image. This is from the Rotten collection. Okay, and this is just one approach to the posterior part of the third ventricle, superior to the pineal gland. Okay, so thank you. I just want to pinpoint, you work in two institutions. At the left, we have the University of São Paulo, and at the right, we have the Albert Einstein Hospital, both located here in São Paulo, Brazil. And we are open to receive guests and neurosurgeons, whoever wants to visit us. It's a really nice city. Thank you for having me, Dr. Ahmed.
Thank you very much, Dr. Eduardo Ribas. Thanks for this great presentation and this nice images and nice explanation. We'll see if there is anyone have any questions before we start with our next speaker. If anyone have any question, please type in the chat or just unmute and ask directly if you want. Let's see here.
Dr. Najiza, how are you?
I think there is no questions. There is only thanks for this nice presentation.
Thank you.
Okay, so I guess then we can start with our next speaker. And after that, if anyone has a question, we can discuss later. There is one question here, I think. For a subtemporal approach to the mesencephalon.
Yes, I'm gonna, well, all approaches, if you want to go intradural, but you don't want to get inside the brain, of course, you will go very close to the inner surface of the dura mater, right? Between the brain and the dura mater, really close to the dura mater. But you want to increase this space. The subtemporal approach, what's going to happen is that you cannot really enlarge too much this subtemporal space because you and draining into the angle that is forming between the transverse sinus and the sigmoid sinus. So you want to study one angiography or a CT scan with the vessels before having this approach, because if you want to see if you have how the drainage of the labial vein is in each particular case if you want to do a subtemporal approach. The pitfall is to retract too much, to enlarge too much the space between the dura mater that's overlying the middle fossa and the inferior surface of the temporal lobe. If you enlarge too much this space, not seeing the labial vein, you might stretch it too much and detach it from its there. So this is the biggest pitfall. The cavernous sinus roof and sinus. This is not really a lecture about the cavernous sinus, but what I wanted to show is that the tentorial free edge is made of dura mater, okay? And this free edge is going to go towards the apex, the temporal apex, the piece of bone very, very medially. So it's going to go to the apex. And from the apex, it's going to open into two dural folds. One that is going to the posterior clinoid, and the other ones go to the anterior clinoid. And between the clinoids itself is going to be a third dural fold called interclinoidal dural fold. These three folds is making a triangle, because it's three dural folds make a triangle. And this triangle is called the oculomotor triangle, and it's really on the roof of the cavernous sinus. And it's called oculomotor triangle because really on its center it's where the oculomotor nerve is getting inside the cavernous sinus. This is, I would say, the most important triangle of the roof of the cavernous sinus. You said about the roof, right? So this is the most important triangle. You have one clinoidal triangle anteriorly that you can just see if you remove the anterior clinoid. If you remove the anterior clinoid, you will see the dura mater that is underneath the anterior clinoid. This is called the clinoidal triangle of the roof of the cavernous sinus. This is a second triangle of the roof of the cavernous sinus.
Thank you very much, Doctor. The cavernous sinus will be discussed in more details with our next speaker. So thank you, everyone. I think there is no more questions. Thank you, Dr. Eduardo Ribas, for your presentation and for your cooperation with us.